Okay. Good evening, everyone. So I'm Katie, and this is Josh, and we are members of the London School of Paediatrics Trainees Committee. And thank you all for coming to this evening session on the virtual clinical MRCPCH. We are recording, and the recording will go onto our London School of Paediatrics YouTube page, which is also full of other wonderful talks, and we will also send out the slides to everyone that registered. So Josh, do you want to say hi as well?
Yeah, hi guys, nice to meet everyone.
So we're going to do a sort of overview of the exam and some of the changes from a virtual perspective. We'll go through a bit of the different stations, and then please do ask questions along the way, and we will do our best to answer them. We are not involved in the exam itself, but both of us have been part of the RCPCH Trainees Committee, and so have been involved in some of the changes that have happened. And so hopefully we will be able to answer your questions, but if not, the RCPCH people are all lovely, and their website page on the changes to the exam is wonderful, and so highly recommend it for any questions we can't answer. So we'll get started. So the aim of the exam is all of medicine, all of paediatrics, but at the standard of newly appointed ST4. So you are not expected to be able to do these things at consultant level. So it's about communication, history taking and management planning, rapport with parents and children, which is obviously a bit different via computer, physical examination, again, very different, child development, clinical judgment, organisation of thoughts, recognition of acute illness, and knowledge of paediatrics and child health, plus professional and ethical behaviour and practice. So all of this is covered by the RCPCH Progress curriculum. So it is supposed to be that you are completing level 1 training and you are at that level. And this is just one step along the way. In terms of the difference compared to the face-to-face exam, most of it is the same. The children, the medicine has not changed. It has been adapted, obviously, for the style of the exam, and in particular, the two stations that changed the most are the clinical stations and the development station, and we'll go into that. But the communication station, history taking station, and video stations are all exactly the same as they were in the face-to-face exam. This is the RCPCH page on the COVID adapted virtual exam, and if you haven't looked at it, please do. Lots of the information that we're going to talk about has come from here, but they've got nice summaries and contact details for extra questions. General information about the exam. So there is obviously a backlog of trainees sitting the exams. They are trying to increase the numbers of people who are sitting and going through the same criteria for the allocation. And the same reasonable adjustments, if they're needed, are going to be in place. You can sit the exam anywhere in theory, but they advise against work because the NHS IT system is what it is, and you can least likely to guarantee IT support there. It is using a system called Praktik OSCE, which is, you probably won't be familiar with, but there's recordings of examples of how it's used on the RCPCH website, and it's pretty intuitive. Every station has an invigilator there as well. So in the face-to-face exam, there would be people walking around and knocking and checking everyone was in the right place at the right time. But for practical purposes, there is an extra person in every exam station, but they are not medical, they are not involved, they just sit there and tell the time. Think about what equipment you need. So you obviously won't have the equipment, but you do have to know what you would be asking for and how you would be using that. With the development station, we'll come to it, but they give you a list and a photograph of all of the things that you have. And we'll go into it a bit more, but everything you're doing is you have to verbalise your full assessment and your examination, and that includes verbalising your permission to examine and how you would adapt to the child's needs, which isn't always as intuitive as if you were in front of a patient. You know, if a child is crying, you would say, I would leave them on their mum's knee so that they were happy, and then I would look at them there. But all of those things that you would do naturally, all of your sort of checking you can examine first, you would do. And when you haven't got that child there, you just have to prompt yourself a bit more to make sure you do it. And of course, there is a potential for technical difficulties with all of these things, as we experience every day now. But they have been very clear that they will not let technical difficulties affect your progress. So they will aim to try and cover any stations that don't work, if that is to happen at the end of the exam or later on in the next week or so, is what they've set. So in terms of the circuit, so this is their sample examination. So it's in 2 sessions. So you've got your long stations in one lot and then your shorter stations in your second session. But those sessions are one after the other, so you don't get a break in between. It's just for practicalities that it's divided up. So you do your extended clinical, your developmental and your history station, which are the 23-minute stations. And then you do your clinical stations, your communication stations and video stations all in one lot too. And you have one examiner per station that is also logged in with you. And there's sometimes also an extra examiner that is examining the examiners and not examining you. And sometimes they rotate in to check what is happening. So this is just a comparison of the pre-COVID and post-COVID situation. So the number of stations and the number of candidates is slightly adapted, although the latest update on the website said that that might be different, but it won't affect the stations themselves. It will just affect the number of people sitting in one session. The total available points is 78, but they haven't announced yet what the pass mark is, but it's been adapted based on the exam itself. And so the station types are listed there. There are no real patients. So they're all either a discussion with an examiner or act as role players, being patients or parents that you're then speaking to. So no actual patients. So it's 168 minutes in total, and normally you would have 4 minutes for the reading in between, but they've added an extra minute for the virtual because of the technicalities and moving between the different virtual rooms. So you have 23 minutes for your longer stations and 2 lots of 9-minute stations for each of the others. And so the marking is by domains, which is the same as previously. So there's the information in gathering and sharing, physical examination, identification of clinical signs, and then the clinical reasoning and management planning and communication. So all of those things, obviously they're slightly different, but they are the same domains. So each station is no longer marked separately, and that's since the year before last. And it's more focusing on those core skills that are demonstrated across all stations, with the aim that then it's not that you fail one station and pass enough others. It's more of it's more fair that it's across the whole way. And it also makes it easier to standardise across different examination centres. So these are the anchor statements. So the aim is then that you get your feedback based on these anchor statements. So it's better feedback should the worst happen and you not pass, that you actually get some useful feedback about what it was that wasn't quite right, rather than good, didn't hear the murmur or whatever, which is not very useful. And hopefully these would be give you a bit more. And the key things just to note is that these things are, I don't know if you can see my thingamabobby, but the at my pointer, the physical examination, for example, well-structured systematic exam technique verbalized is the key difference, that all of these things you have to say them rather than do them, but they are all the same largely as previously. All of these things are available on the MRCPCH website. So this is just a summary looking at how the domains are then shared between the different stations. So obviously not everything is covered by every station, but they gradually are all covered. So the marking then works across those 5 domains, marking each as 0, 1 or 2 for below standard, borderline or meet standard, for which obviously you will get meet standard for everything. There's also a domain of professional conduct, so it doesn't count towards overall mark, but that is then considered. So sort of unprofessional behaviour, which in theory is potentially harder to do virtually, possibly, and is unlikely, you aren't necessarily would fail based on a single mark of that, but would potentially accumulate. And then I know some people like to be strategic in their revision and only revise it, like revising more for the things that give you more marks. So these are how much the % of each of the stations counts. I mean, you know, you need to revise it all, don't you? And that's for the different domains. Fab. So we're just going to go through some of the clinical, some of the different stations, and then some sort of tips and things. But are there any questions so far? Ooh. Not yet. Smashing. Just Josh. Lovely. So the next one is the clinical stations, which I believe is me again, Josh. Is that right? Did I imagine that?
Yes, go for it, Katie.
Wonderful. So clinical stations. So this is one of the areas that has been adapted between the different forms of the exam. So you, the aim is to assess the candidate can take a structured and systematic clinical examination and identify those clinical features. The 2 types are the extended and the short clinical. So the short clinical is like what we're used to. So it's a 6-minute examination and then 3 minutes of discussion. So that is like the face-to-face exam. The extended clinical is more like the long cases that used to be, but actually they're also more like real life. So they do make sense as an exam structure. So you have your 10-minute history taking with your focus, and then a discussion of 2 minutes with the examiner where you decide what exam you're going to perform based on your history. So if the history has been all about asthma stuff, then you would do a respiratory exam or whatever. If it's about them falling over lots, then you'll decide whether it's neuro or gals or whatever. Then you spend your 8 minutes doing your examination discussion, describing your examination and getting the feedback, and then your 3 minutes of discussion at the end. And again, all of these things were at the standard of a newly appointed ST4, so you are not expected to be able to do a perfect examination of the heart like a cardiology professor. You are supposed to be able to examine a heart and talk about it in a sensible way, so that if you are on call overnight and you call your consultant, they know you can say something sensible. So in terms of what is covered, anything can be covered. This list is slightly helpful and slightly unhelpfully provided by the MRCPCH, in that areas that could be covered is everything. But it does give you a sort of an idea of the things that are covered. There are no real patients, so it's all videos and descriptions of the examination. And there's role players in the extended clinical station for the history part, but not the short clinical stations. And then you need to talk through your examination and then be given the findings. So this is how it works. So it really just needs practice. So you need to be able to describe the physical and for the development, describing your examination. So you have to have your structured systematic examination, but also be ready to get the information as well. So think about what it is you're actually asking for. So I would look at muscle bulk and compare both sides, look to see if there is any wasting, pause a breath and get the feedback from the examiner. So I was one of the people that did the pilot exam, and it really just takes some practice. It doesn't necessarily come naturally to be able to talk through an examination completely without it becoming a list. So it does take a little bit to make sure that you are going through it in a structured way, like you're examining a child and getting that information back in exchange. And there's two different types of cues, which is the information about the child. So there are the dependent cues. So these are the things that you ask a question and they give you a response. So once you say a specific step, they will give it back. So I would test the lower limb reflexes with a tendon hammer, and they say the reflexes are brisk on the left. And so do be ready for them to say those things back to you so it doesn't interrupt your flow. They have said that they might raise their hands if you haven't paused for them. It's also worth bearing in mind that you have to say enough for them to give you the information. So like if you say, I would look at the chest, they might not give you all of the information, whereas you might have to say, I would look at the chest looking for scars or chest deformity, and then they would say there is a scar here or whatever. So you do have to give a bit more than just the basics. And if they prompt you, they can prompt you a few times, but in terms of the marking, if they have to prompt you too much, that might just shift you slightly in terms of your mark. So that's the dependent cues. The other type of cues are the universal cues. So these are the things that you get without having to ask. So they're given at the start of the session, and so you see them within your reading time. They are the things that you would see when you walk in the room. So if there's, you know, a wheelchair or a big scar or a loud wheeze, and they have photos, there's audio and video recordings that you can watch or listen to as many times as you like before you start. Because of the practicalities of the computer systems, sometimes some of the dependent cues that you might not find out, like a murmur, if they've got a recording of a murmur, even though you wouldn't necessarily hear it until you got to that stage of the examination, they give it to you all at the beginning. So in a way, that's a silver lining for you. So you can listen to all of those things at the beginning. They are also available for the whole of your station, but it is a bit faffy to go back and listen to it again. So what is expected is an organised approach, a clear and systematic pattern, and looking like you've done it before. And as I say, it's trying to do a systematic exam without it sounding like you're reading a list, which just takes practice. You should be competent at assessing all areas of the child and identifying those signs and discussing the findings and interpretation. And this should be at the level of a newly appointed ST4. And the presentation is part of your key things in terms of getting your marks, because that is where you prove that you can pull it all together. So even with all of your good examination, having a good presentation of your findings at the end is very important. So don't forget to practice that bit, and do develop a structure. Start with your main findings, then your differentials, and you could even start talking about management, but they might cut you off and go for what they specifically want. And do practice how you're presenting. You might have noticed that I wave my hands a lot, and I definitely got, when I am nervous, I get even more handsy. And so for the examination, do whatever you do, whether it's sitting on your hands or things, and looking at how you're presenting, because there are some of the non-verbal things that you can do through a computer, even if it isn't face-to-face. This document is definitely worth a read. So this is on the MRCPCH page, and it tells you how to do all of the exams. So each of the examinations, they tell you what they want. So read it and learn it and thank them. Just have a look at it. Smashing. Fab. So that is basically the the clinical stations. Any questions, or we'll go on to the development station?
Perfect. I'll jump in then here, guys. I've requested control, Katie, if that can work. Oh yeah, looks like it. Perfect. Okay, so the aims of the development station then, same as before, of course, to assess the candidate's ability to undertake an assessment of key areas of development and also to take a focused history, exploring the reasons for those findings.
It's gone a bit weird. I can see all of the presenter view.
Okay, should we just go back to the other one and you can move on for me?
Yeah, I don't know how. Yes. Try clicking. No,
that's okay. I can't control it, but
just
that's okay.
Thank you.
Thanks, Katie. And so yeah, we have a developmental assessment component to the station, and we have a history component essentially, and also emphasises the impact on the child and the family. I think that's a really important theme to emphasise throughout the whole of your exam, really, particularly the developmental station, but throughout. Really, really important that you're always thinking about the kind of social implications and aspects of every single station. So you're going to have to gather some information, you're going to have to conduct the developmental assessment, and then there will be a discussion with the examiner as well. And you will have some toys and other equipment available to conduct your assessment, and I'll show you a photo of those in just a second. As ever, it's a standard of newly appointed ST4. Some of you may have done community jobs, in which case you might be a bit more comfortable with this stuff. Most of you won't have done, and that's absolutely fine. As ever, it's the standard of a newly appointed ST4, so not the standard of someone who has done lots of community paediatrics or indeed any community paediatrics. You just need to be prepared. And another important one in blue there is that the children will have a developmental age of less than 5 years, or up to a maximum of 5 years. So they could theoretically be older chronologically than 5 years, but their developmental age will always be less. So you don't need to be learning lots about kind of psychoeducation and that sort of developmental assessment in older children. Next slide, Katie. Thank you. So what's going to be expected of you? You're going to have to gather key information with history taking. So that's the first aspect of it, is the history taking. That lasts for 10 minutes, and then you have an additional 2 minutes of discussion with the examiner. The idea of that really is just to summarize your history, and then you'll have time perhaps for 1 or 2 questions, but not more than that. It's mostly to summarize the history. And you'll then progress to the actual developmental assessment, the kind of physical examination side of things. And really importantly, you only have 8 minutes to conduct your examination in inverted commas. Obviously, it's all done verbally. And so you're not going to have enough time to be carrying out a full developmental assessment of all 4 domains. There's going to be a maximum of 2 domains that you're expected to assess. Often that will be 1, sometimes it will be 2. And by those domains, just to be clear, I mean the things like gross motor, fine motor and vision, etc. So often there'll be 1 of those, sometimes there'll be 2 of those, never more than that. You have 8 minutes to go through what you would want to assess using the verbal dialogue that Katie's described, and then you have a 3-minute discussion to wrap things up at the end. So that brings you to your total 23 minutes. And the ages we've provided here are alluding to how accurately you need to be able to determine the developmental age of the child. So it's not the only goal of a developmental assessment, but it is, of course, an important one. It's kind of working out the developmental age of the child in the particular domain or domains. So they have different ones depending on the age of the child that you should be aiming to achieve. So for a developmental age of 2 or lower, you're expected to get it within around 3 months. However, if the child's a bit older, between developmental age of 2 and 5, within 6 months is perfectly reasonable. So you don't need to be learning developmental milestones at greater resolutions, if you like, than that. Syndromes is an important one. The child in the scenario may or may not have a syndrome or some sort of neurological abnormality. It's really important to emphasize, though, that you're here to assess the development in this station, and you do not want to be spending lots of time talking about the syndromic features and neurological issues that may or may not be there. If you notice them, then make a comment on them by all means, but certainly don't spend loads of time going hunting for those things or talking about them if they are there. Just briefly mention them, that you've identified them, and then move on, spend time on the development. And part of the discussion, particularly the 3-minute discussion at the end, will include a suggested management plan of how you're going to help support that child and family. So here is the toolkit that you will all have available to you. And so this is helpful because it means that you will have a common set of items that you're working from that you can suggest you would want to use. And it's comprehensive enough. There's no need to be using anything that's outside of this. And you also definitely don't need to be using everything that's within this. And it may be that some people find some things easier to work with than other people, and that's absolutely fine. You just go with whatever works for you. So have a think about each domain and how you might want to use these items to help you achieve that. So the first part is taking the history. You want to be treating it just like any history, but again, you don't have very long, so you need to be pretty efficient. You can think of it in the usual structure: history, presenting, complaint, past medical history, etc. But the emphasis is clearly on the things that are listed here. So you want to be exploring the likely cause of any developmental delay. So birth history particularly. Past medical history is always going to be relevant, particularly with any neurological insults. Family history of developmental or learning issues. And you want to confirm whether the delay is an isolated issue or whether it's across all domains or multiple domains. And there may be associated comorbidities, ADHD, epilepsy, autism, and all of those things may be alluded to. You may want to ask some very, very brief screening questions to elucidate those things, but don't spend lots of time doing that. And then really, really importantly, you do want to spend a lot of time assessing the impact of the child's difficulties on the family. So exploring the social situation, what support they already have, and where the support they're getting is not enough. Education plan within that also, do they have one already? What type of school do they attend? And also, if it's a child who's already linked in with healthcare services, then who's involved in their care within the multidisciplinary team already? So just some top tips then. Practice is going to be really important. It's very possible or probable that lots of you aren't feeling very comfortable about this one and don't have lots of experience in developmental assessments. I know I didn't. And so practice is important, and particularly when it's more unusual and doing it all virtually. So as with all of the stations, you can practice with a friend, you can practice doing it over a Zoom call or whatever. I think that's a good way of practicing, because then it will be as lifelike a reflection of the exam as you can achieve. We've got look around written there. I guess that's just worth a statement at the beginning of your discussion, saying that you would have a look at the child and the whole and their environment. You might get important information. Don't neglect those things just because it's verbal. And the way you approach the developmental assessment is by starting with easier tasks and then moving on to harder ones until you find the child's limit of what they're able to achieve on that day. And when we say start with easy tasks, you don't need to start at what you would expect a developmental age of 3 months to be able to do for a child who is 4 years old, for example. You start with something that's semi-appropriate, but aim on the lower side. And then if they're able to do that, then you progressively move to assessments corresponding to a higher developmental age until you find the limit of what the child's able to achieve at that time. And that brings us to the final point, which is just be careful with how you're phrasing things and not to be too negative, saying that they're not able to do something at all. It might just be that the environment and that particular time are not conducive to the child's best abilities. So just be careful with how you phrase things. This is really, really helpful. This is a resource that we've got available. You can have it on the screen here, of course, and we can send out digital copies as well. But this is essentially all of the information you need to know for your developmental station on one A4 page, which is really nice. You don't need to know any greater level of detail than this. There are loads of big old textbooks, etc. out there about various developmental milestones, but often they're too much detail. They're more than you need, and you're not going to be able to memorize it all anyway. So this level of detail is completely reasonable, completely sufficient. You will get differences if you are looking at other resources as well. You will get slight differences in the milestones. That's okay. That's a well-known and accepted phenomenon. Sometimes there's not complete agreement about the corresponding age for a particular milestone. You just use whichever one you've learned and stick with it. It will be reasonable. So that's it for the developmental station. As ever, guys, if you've got any questions, please do just pop them in the chat or raise your hand, or save them up for the end, however you want to do it. Next up is the history station, another one of the longer ones. So the aims here are taking a focused history, focused being the important word there. After you've done that, you'll have to summarize. You need to be able to pick out the key issues within the history, not just regurgitate the whole thing. You need to prioritize those issues and then formulate a sensible management plan. The problem that you're facing will either be something completely new, a completely new presentation, some examples given there, or it might be a specific problem in a child with known chronic issues, such as weight loss in a diabetic child, feeding problems in a child with cerebral palsy. Equally likely to be either of those things. There's no examination component to this history station, but you may be given some additional info, so don't be perturbed if that happens. You might be given things like growth charts, anthropometry, or even some test results at times as well. And usually that information will be provided at the beginning of the station, and then just provides a little bit of extra information that helps you focus your history and draw out the relevant information. What's expected? Be friendly, polite, professional. All of those things are good, aren't they? Really important, actually. I think it does make a massive difference if you just come across as kind and friendly throughout. And I know it's more difficult when everything is done over a screen, but still, I think try your best, because it does still make a big difference. You need to be able to relate to the parent, carer, and young person. Again, more challenging over the screen, but give it a good go. Your history wants to be focused. That word keeps coming up, and quite rightly so. You want to gather sufficient information, though, to determine the problem. The questions that you're asking to achieve those things, they need to be clear. They perhaps want to be open at the beginning and then becoming more closed as you progress. And avoid jargon. You don't want to create any confusion. Again, you want to be covering all aspects of the history. Whilst being focused, you do want to cover all aspects, and you're going to have to spend more time on the areas that you feel are more important to that particular scenario. It's very probable that the social situation, as I've alluded to, is going to be a relevant area. So often that's in the end of people's structure of their approach to the history. But don't rush that. You want to save some time for that, because it's very possible that there'll be quite significant social issues. So you definitely do want to leave some time in case that is the case, and then you've got sufficient time to explore those. It's got some specific things there not to forget: immunizations, allergies, medications. You might need to ask if they're taking their medications and any problems there. You might need to ask about previous treatments and medicines that they've had in a more chronic patient. And exploring concerns, ideas, and worries is a really helpful thing for both the parent and the child. Obviously, it may be that you get some questions or some queries directed towards you as you proceed through the history. Probably that won't be happening lots, but if it does, then just take it in your stride and give appropriate, sensible answers. If you're not sure, then say you're not sure and how you'd address that. You need to be kind, show empathy and willingness throughout, of course. And then at the end of taking your history, you'll be summarizing it to the examiner. sorry, this is saying something slightly different, isn't it? This is saying summarize with the young person and the parent, and then invite any extra information that they feel that you haven't fully covered. That's a really sensible thing to do, because if you have missed anything, then they probably will be kind to you and just offer it up. And then at the end, you'll have a discussion with the examiner. You will be summarising the history very briefly. You don't want to spend a lot of time on that, and that's definitely something that needs to be practiced. And then you just need to come up with a sensible management plan for further tests and treatment. So as we just said, don't regurgitate the whole history when it comes to presenting it back. The examiners have just sat there and heard it. So some people like to structure their concise summary by using a problem list style approach, like you might find at the top of a clinic letter, for example. Other people are more familiar with using SBAR as a kind of handover type tool, and either of those work perfectly well. It's just whatever works for you. Again, emphasis on the history being focused, really, really important. You do need to tailor it to the situation because you don't have a lot of time. And you can always try to anticipate some of the examiner's questions. You can do that in the 4 or 5 minutes before the station actually starts. You might be able to start thinking about some of the questions and discussion points already. Or if you have time at the end after taking the history, then you may well be able to start thinking about how you're going to summarise to the examiner and also some of the questions that they'll ask you. And if you do have time at the end after taking the history, and this applies to all of the stations, that's absolutely fine. That doesn't mean you've done anything wrong at all. In fact, probably it's a good thing, because it means you haven't rushed the end, which happens, I think, to all of us more commonly than we would like. So if you do wrap up a bit ahead of time, take that as a positive for sure. Any questions about the history station at all, guys? Again, pop them in the chat, raise your hand, whatever you want to do. But we'll move on to the communication station in the meantime. This is quite brief. So this is 2 shorter stations. The aims here are clearly all about communicating, doing it appropriately, conveying factually correct information. That's really important. You don't want to be pretending to know more than you do because you feel like you should, because it's an exam. Sometimes they'll even be a little bit sneaky and seemingly kind of stretch you with stuff that you're obviously not going to know the answer to. So just be careful. Don't fall into any traps. Not that there are lots of them by any means, but the point is, if you're not sure about something, it's completely fine and it's correct to just say that you're not sure and offer a solution of how you would find out that information and get it back to them. And often you'll have a role player in these communication stations. So it might be anyone, it could be a parent, it could be an adolescent, unlikely to be a young child, of course. It might be a health professional, or it could be a member of the public even. So it really could be anyone. And it can include a telephone conversation. I guess that's a little bit less relevant now because every kind of scenario feels a little bit more similar to a telephone conversation anyway. The examiners will just be observing here. They won't be involved with you at all. So the whole 9 minutes, they'll obviously introduce themselves and direct you, but they won't be expecting you to talk to them, and they won't be talking to you after that. So here are some of the types of scenarios that you can have, or indeed all of the types. They will fall into one of these categories. Information giving is a relatively common one, an example being to explain a diagnosis to a patient or a parent. There can be some breaking bad news type scenarios, for example, explaining the results of a test and what that might mean. Consent is something that can come up, for example, why we need to do a lumbar puncture. Critical incidents, these are relatively common. So, for example, talking to a parent of a child who's been given the wrong drug, and all about duty of candor. Ethical scenarios, again, will be common. So if someone has refused to have blood tests, as the example given here, you have to have a discussion with them about that and how you're going to proceed. So a little bit of basic knowledge about law and ethics is required. And education scenarios, again, are more and more common. So if you have another healthcare professional particularly, but it could also be a parent or younger person, then explaining to them how to deal with a particular situation, or Might even be a very brief teaching session on a subject to another junior doctor, for example. Briefly, what is expected in these ones? It's all pretty generic stuff and stuff that you would expect. It's essentially being a kind and nice and emotionally appropriate person. Again, do have a think about your body language. It is more challenging, of course, but still just do have a think and practice it with your friends and give yourselves honest feedback. Don't just be nice to each other. Give yourselves good, critical, but productive feedback. Pick up on verbal and non-verbal cues. Again, more challenging, but still possible. Definitely needs to be a dialogue and not a monologue. Should very much be a two-way conversation, and often if you're actually not saying very much in these scenarios, that's quite a good sign and probably means that you're doing quite well. And linked into that, I suppose, is the importance of active listening. Don't be afraid to use silence at all. That's absolutely fine. Can be quite effective in certain scenarios, whether it's breaking bad news or other things. You want to be empathetic. That's going to be really important. Give clear and accurate explanations. Use diagrams. That's going to be pretty challenging with the setup the way it is, but it's not completely impossible. You could certainly offer that, and do show professional respect for a colleague if they're not a parent. So you have to tailor the way you're interacting with the person depending on their role, of course, just as you would do in real life. And you do need to address the task set. Some of these tasks can feel a little bit fluffy potentially, but they all will have quite a clear task associated with them. And if you're not clear on what the specific task is, then do ask the examiner. It is completely okay to ask for clarification on this and any of the scenarios. That won't be looked upon negatively at all. And an important point would be to check the understanding at the end of the communication. So when you're wrapping up the scenario, I think that might be information we're coming to on the next slide, actually. Yeah, here we go. So it's certainly not a test of the sheer amount of information you can communicate. You might be fortunate enough perhaps to come across a scenario that you're really familiar with and you do have loads of information. In a way, that can be quite a difficult situation because you have to be quite careful about selecting the information that you do need to convey. So when you get to the end, you might choose to do this when you hear the kind of 3-minute warning towards the end. You might want to do it earlier, whatever you want to do. Important things to do at that stage are to summarize everything that you've been through. You want to be checking the understanding of the person that you're in the situation with, whoever they may be, and answering any questions that they may have. Make sure you do explicitly invite questions. And then importantly, you want to offer up a plan of action for going forwards, where you might have your next meeting or pointing them in the direction of other resources that might be helpful and that sort of thing. So those 4 points should be how you kind of close any of these communication scenarios, essentially. I think those try 2 points we've mostly covered along the way. Yep.
Fab. So the video station, so this is quite a quick summary. The aim of the video station is to assess the ability to make clinical observations and decisions and identify clinical signs which can't be easily assessed in other parts of the examination, which is a bit less critical with the current format of the exam, but it does mean that the video station is designed to look at those sort of acute signs which you wouldn't necessarily see in a routine exam. And then your discussion of your clinical reasoning around that. So the things that it is likely to cover compared to the clinical stations is acute problems like respiratory distress, seizures, but you can get clinical signs that might be similar in style to things you would see in the clinical examination, but it's addressed in a different way. So you're shown the sign and then you talk around it. But things like skin rashes often come up, or it could just be simple observations. So a video of someone grunting and then a discussion around a child like that. And the my main recommendation for this would be just to go in a YouTube hole, because there are the number of people who just put videos of their children on YouTube. But anything you can imagine that you want to look for, there will be something there. and it's good to have a rummage, and there'll be descriptions of what's happening underneath. So that's all for the video station. Really, it's the same as the others at this point when you're doing it virtually. So some general tips around the exam. We haven't got any questions, have we yet? There was a question about Josh. I don't know if you want to answer. Ethics in a situation of a patient refusing bloods, falling under the umbrella of competence within teams or parental responsibility as per legal ethics.
Perfect. Yeah, I'm just typing up an example, so an answer. Sorry, Katie, so I can finish that off.
Smashing. I will just keep going then. Revision type tips. So practicing talking is definitely the key. It's just not how we examine, and so it's just about making sure that you transfer your knowledge that you all have into the format that is required here, unfortunately. Find someone to practice with and keep practicing with them, and as this will be online, then that can be online meetings, so they don't need to be at your hospital anymore. Be honest with yourself and do keep pushing yourself, and don't just say, oh, it's nice, and get people to teach you. We have all been through it, and everyone else had to make people teach them, so they can teach you. Have no shame and get people who scare you to mark you and examine you, because that is what it's going to be like. Obviously, you just need to throw yourself into it, unfortunately. And of course, fortunately, there's nothing else fun to do at the moment, so it's okay. But do take time and don't go mad. You do need some breaks between it all. Use your study leave. You are allowed to use your study leave for revision purposes. There's a limit and it's slightly different in different places, but you can, that is a thing. Seeing real children is obviously a question at the moment in terms of whether it is as useful necessarily when it's actually descriptions and those sorts of things that are going to be shown to you. And of course, in terms of social distancing and not putting vulnerable children at risk by being examined by lots of people, but there's risks and benefits. You can, of course, you are doing this job every day. You are seeing children, and just when you were examining a child in A&E, you adapt what you're doing to make sure that you are doing a full examination, because obviously no one ever does a full cardiovascular examination, including looking at the hands in real life, but you should be doing that now. And don't forget the video station. Think about those other things that you would be doing. But again, you see, this is all real life. It's all things that you know. It's just doing it in exam conditions. Make sure you time yourself and stick to it. Do it under exam conditions. I was particularly bad at making sure that you time yourself for the examination bit, and you time yourself immediately after for the presentation bit and the discussion, because you don't have any time to think in between, and make sure that you do it properly. Practice presenting. The presentation you have to have slick. Get your patter down. I am bad at saying and a lot, and I have to stop myself, and I'm sure there are others who do the same. Revision sessions and mocks. There are a few around. I know Great Ormond Street always does one, but it fills up quickly. I don't know who else is doing courses. If you do have any suggestions for people, then do stick them in the group, in the chat. Revise your small print examinations. Don't forget about the bitty things like thyroid exams and how to use a Snellen chart, which we don't do all the time, but is good to know. And think about your communication and history. Sometimes it's easy to get bogged down in all of the clinical examinations and forget. I've got a picture of different resources and things, but there's a pink book of communication stations and history, communication station things, and you just need to work your way through, and that will cover almost anything that can possibly come up, really. familiarise yourself with your equipment, particularly with the developmental one where they have that picture. That picture is shown to you in the exam, so you can know before you get there what you'll be using. And use the mark sheets whilst practicing. The RCPCH have been nice enough to give you a booklet of how they want you to examine and a mark sheet of how they will mark you, so make the most of it. In terms of pre-exam, make sure you've got all of your IT things sorted. Having from the practice, the pilot, you get so many emails and it's so easy to lose one of them. This is a list of 6 emails that you receive. I'm sure that there are more. With all of your different links and your different access, you have access to the Slack page, which is if you get lost in Practique and need help, they help you. So just admin gathering. For the session itself, remove all your distractions, lock your children and pets away. You still need your ID and your admission document to show to the camera to prove who you are. You can have water with you and you don't need to dress fancy, obviously, but it is on camera and they can see you a bit. You are doing what you do every day and you've got this far, so I'm sure you'll be fine. Just do it and do it with confidence. That is part of it, is imagining yourself as the registrar. You are the registrar, you can do it, just sound like you need to do it. Part of it is always acting. You can make notes. So this was something that they had said no to previously, but they've said that you are allowed to take notes, because particularly with the history station and things like that, sometimes you do need to take notes to make sure you know what you're talking about and you haven't missed things, but just you need to get rid of them afterwards. Sometimes you have a station that goes wrong and it happens. Just forget and move on. Don't let a station that you think you did badly in affect the next station, because often it didn't actually go as badly as you think it did, and it's the next station that then, if your mind is all in a twizzle, then things can happen. Don't make up signs. It's harder to do now because they give you a photograph or tell you, but there are things like the recordings of the murmurs and things like that where sometimes it is a normal heart sound, and don't say there's a murmur just because you think there must be something that you've missed, because that is more concerning than not picking up a sign. Sometimes examiners do get it wrong. This is not a perfect system for anyone. If you think that something's gone wrong and they've interrupted you or done something that has thrown you, then do raise it, and raise it on the day, because that's when things can be addressed. The examinations, in theory, they've said that when you're signing up to the exam, they're recorded. How much that is used in terms of going back, but if there is a big issue, you can go back to that. You're part of this Slack channel, so if on the day there are issues and the IT fails and you've got thrown out, then if absolutely needed, you can contact the examiners and organise through that, and they can help you get back on track. And of course, just forget about it once it's done. The results will be ages. They said that it could be less than 6 weeks. Now it's all virtual, and so it should be easier to process, but it does take a while. So don't spend the next 6 weeks in a slump about it. And it doesn't always go perfectly. I passed second time round. In terms of the things that made a difference, I think it was about practicing with people who made me work harder and were mean to me in a useful way, and about confidence and doing power stances to make myself feel that I am the reg. They were sort of the key things for me for the second time. But there's a consultant at my hospital who passed the 7th time, and he is fantastic, and so it doesn't matter. And revising for your exam does genuinely make you a better doctor. This is the most useful and practical of the examinations. You do learn a lot in the process of preparing. Sometimes it is just luck. sometimes the things that come up, you just doesn't work for you, but sometimes there is something identifiable and just don't do it again. You get a copy of all your mark schemes, including all of the comments. They should give you some useful feedback and advice. In theory, previously, if you were borderline, it would always be useful to do a remark, but they have changed it a bit, and so it is a bit less likely. You have to pay for it, and not as many, because the system is fairer now. Fewer people get marked up, but the examination is being recorded, and so if you really think that something didn't go right, then there is that option. These are just some of the things that we have found helpful. The MRCPCH website, I have said it a few times, but do look at it. It tells you what to do. This website is the MRCPCH Pediatrics website is from the London School of Pediatrics, and it has lots of, it's this one in the middle, has lots of recordings of stations. Obviously it's based on the face-to-face, but definitely gives lots of good advice, and that is where the developmental milestones in a page comes from. YouTube for all of the videos, guidelines and things are useful. You don't need to know everything, but you know, if you've taken a history about asthma and it's about stepping up your inhalers, having that BTS guideline in your head is a good start. Think about Epicure and BAPAM guidelines in terms of if you're counselling for preterm birth and things like that. There's lots of lovely podcasts like Peds Pods and Dragon Bites that have good quick summaries of different topics. This pink book, the communication scenarios book, is great, and I'm sure it will be available in your hospital library, or one of your colleagues will have it, so don't buy it unless you have to, and don't buy it from Amazon. The past test book is obviously good and goes through all of the stations. There's a couple of older ones. These past pediatrics ones, circuits and pediatric exams, are old and they're from several iterations of the exam ago, but they do have good clear summaries and nice things. This From Birth to 5 Years book, some people love it. Personally, I didn't find it very helpful. It goes into more detail than you need, but some people like it in terms of the structure, learning the development. And of course, look at the syllabus, because this exam is part of your level 1 syllabus, and coming to the end of level 1 and starting level 2. So that is the level that you are expected to be at. Fab. So that's it. Any questions? And of course, good luck. Anything else in the group so far? Smashing.
I think we're up to speed with the chat, unless I've not answered any questions fully, guys, in which case please do let us know. Do shoot with any questions, guys. I know it's a bit weird talking on here with everyone, or write in the chat if you prefer, but we've just spoken at you for a while with a lot of information that you can get from other places, but potentially asking us some questions is really helpful, so do feel free to take advantage of that if you wish to. Yeah. And as we said earlier, so this is being recorded. We'll put it on the London School of Paediatrics YouTube page in the next few days, and I will send an email out to everyone that booked on the Eventbrite with a copy of the slides and a couple of those links that we talked about. So if anyone is here that didn't book on there, just stick your email address in the chat and I'll send it to you as well. Fab. Any other questions? You'll all be okay. You all came to here, so you are all enthusiastic people, and so you'll be fine. Smashing. That sounds like everyone's all right. Okay, great. I will stop recording. Oh, can I stop recording?